So the zinc deficiency, it also causes the acrodermatitis enteropathica. Zinc deficiency also causes the acrodermatitis enteropathica. Okay, is my voice clear? Everything is clear, right? Okay. So there we have the, it also causes the acrodermatitis enteropathica. Then let's continue further onwards, and we was in the question number, कौन सा क्वेश्चन था? This one. A 90-year-old man was admitted to the receptions department in the 20 minutes after the being wounded with the knife to the left chest. The patient is confused. The heart rate we see the 96, blood pressure is down, the dilated neck veins is there, and we see the sharply diminished apical beat. Sharply diminished apical beat is there, and evident heart enlargement. What kind of penetrative chest wound complication has developed in this patient? So what we call this condition as the cardiac tamponade. So we have the two conditions here. Did I teach you the cardiomyopathy? Did I teach you the cardiomyopathy before? पढ़ा है? अच्छा जी. I don't remember. Okay, in cardiomyopathy we studied what? The dilated cardiomyopathy, the restrictive cardiomyopathy, and the HOCMs, hypertrophic cardiomyopathy. तो एक क्वेश्चन आया था, 2018 पेपर के अंदर. Then why you didn't tell me on that day? Dilated cardiomyopathy, restrictive, or HOCM. So HOCM, the increased systolic pressures. So what we see is symmetrical septal hypertrophy, and in the dilated cardiomyopathy, what we studied, that there will be the, what we see, the left ventricular failures like the dyspnea will be there, and the restrictive cardiomyopathy, right ventricular failure like swellings. Yeah, I remember that I teach you. Okay, then let's continue further with the two main pericardial diseases. So two main pericardial diseases we have, that is a, okay, let's do it here only. So we have the two pericardial diseases, and in pericardial disease, the first one is we have pericarditis, or we called it the pericardial disease, or we called it acute pericarditis. Acute pericarditis. See, if question about the acute pericarditis will comes, so you will see that there will be, in the questions you will get, there is a sharp chest pain will be there. There will be the sharp chest pain will be seen. The sharp chest pain will be seen. Along with that, you see this patient's this pain will be radiate to the trapezius. This pain will be radiate to the trapezius muscles. This pain will be radiate to the trapezius. Peri means, the peri means penny. Peri means penny. You can remember like peri, penny, penny, peri, peri, penny. Okay, that means you will see there is a penny, that is the sharp penny, that is the sharp pain you will see. Then after that, in acute pericarditis, the signs you will see that you see there is a pericardial rubs. That is very important signs. That is the pericardial rubs you will see. After that, you will see the ECG. On the ECG, what you see, the PR segment will be decreased. The PR segment will be decreased in case of the ECG. The PR segment will be decreased in case of the ECG, and ST segment will be elevated. The ST segment will be elevated. ST segment also elevated in myocardial infections. Okay, that is STEMI, ST elevated myocardial infection. So ECG, what we see, the PR segment will be decreased, and the ST, PR segment duration, the duration of the PR segment, we have the PQRS or T, the PQRS or T. Then what we see, that P, and this is QR. So this will be reduced, this duration will be reduced in case of the acute pericarditis. Along with that, we see there will be the ST segment. So we have the S here, so we see there is a ST segment elevations will be seen. So that is seen in case of the pericardial disease. For the treatment, also remember the treatment, we can give the aspirin as well as we can give the ibuprofen. We can give ibuprofen. So aspirin or the ibuprofen can be given in case of the acute pericarditis. After that, there is a similar type of conditions. So that is the cardiac tamponade. That is the cardiac tamponades. So in the cardiac tamponades, remember that cardiac tamponade. So it is similar things like the tension pneumothorax. Okay, because in the tension pneumothorax the tensions will be generated, and here also the similar type of the things will be there. In the cardiac tamponade, what we see there is a pericardial effusion. The pericardial effusion means that outside the heart we will see there will be the loads of the fluid accumulation will be there, and that effusion what it will do, it will compressing the heart, and that will lead to the dyspnea in this persons. After that, what are the sign we will see? The sign is again very important sign here is in this cardiac tamponades. There will be the low blood pressure. Low blood pressures will be seen. That is the low BP will be seen. Along with that, we see that there is a JVP distensions, or we can say the central venous pressures distensions, or the neck vein. We call this as the neck vein. So the neck vein distensions will be seen. Or the superior vena cava will be prominent also. The superior vena cava will be prominent in cardiac tamponade. Along with that, what you will see, heart sounds will be muffled. The heart sounds will be muffled. Muffled heart sounds will be seen. Muffled heart sounds will be seen, or the soft heart sounds will be heard in these conditions. And why the heart sounds are muffled or the soft? Because the heart is now surrounding with the loads of fluids. So due to which the heart sounds will be heard as a muffled sound, or the soft sounds will be heard. We call this stride as the backstride. Backstride. The backstride, this is seen in case of the cardiac tamponade. The backstride is seen in case of the cardiac tamponade. Low blood pressures, neck vein distension, heart sounds will be muffled, and the soft will be theirs. Okay. Then if we see the ECG conditions, on ECG what we will see? On ECG we will see there will the QRS complex amplitude will be changed. The QRS complex amplitude will be changed. And we call this condition as the, like if the QRS complex amplitude will be changed, so there is some pulses formations will be there, and there will be called the pulsus electric alternance. Okay, that they will not ask you in the Croc 2, but if you want to remember, there will be the electrical alternance, because you will see there is a QRS amplitude will be changed. Like for examples, if this is my ECG, okay, I'm making here, like if this is the ECG, so you will see that it will be the amplitude will be changed. The amplitude of the QRS complex will be changed, and we call this condition electrical alternance. Like the wave pattern will be the electrical alternance will be theirs. And for the treatment, what we will do? The treatment, pericardiocentesis. Okay, and this pericardiocentesis, of course, that will be the echo guided will be there, and it is like we will pierce that punctures, or we aspirate through the subxiphoidal area. So we will, and then we will remove or aspirate all the pericardial fluids, so that we can easily treat these conditions. Okay, so that the main thing you need to remember, the hypotension will be here, the neck vein distensions will be here, and the heart sounds will be muffled, and the soft, that is the main sign we will see in case of the cardiac tamponades. The main sign that we will see in case of the cardiac tamponade, that you need to remember. Okay, is that clear? And after that, there will be the acute pericarditis condition. There is one more conditions, we call that the constructive pericarditis. We call this condition as the constructive pericarditis. Constructive pericarditis. When we talk about the constructive pericarditis, what we will see? We see there is a failure of relaxations. There will be the failure of relaxation. Means the heart is there, then heart will not able to relax properly. So because of the pericardium, and this pericardium will become stiff. That's why we say this is the constructive. So failure of relaxation. due to stiff pericardiums, and we call this condition as the constructive pericarditis. And due to this failure of fluctuations, we will see there is some swellings will be seen. The sign we studied in acute pericarditis, what was that? Pericardial rub. Here we will see that there will be the pericardial knock. The pericardial knock will be present. Okay, means what will happen now? The heart is not able to, the ventricles are not able to relax. So what will they will do? They will do knock. They will want to relax. So for the relaxation, they want to open their area, but this area is constricted. So that's why the ventricle walls, they will come out and they will strike and they will say knock. So that will be the pericardial knock. Okay, the knock, where they will knock on the stiff pericardiums, and that's why we call this sign as the pericardial knock. What about the ECG? As you see, this is the constructive thing. So everything will be decreased. All voltage will be low. So in this condition, this is the more severe condition. So in that we will do pericardiectomy. We do the pericardiectomy. We will remove the whole pericardiums. Okay, that you need to remember. There is one more beautiful feature, difference between the acute pericarditis or the cardiac tamponade, but I think that is not in the crow, but I am writing it still here. Okay, if you see that question, because there are no questions I think about the JVP. And if you see the JVP means jugular venous pressures. In the jugular venous pressure, what we will see? We see there is a waves will be there, like X wave, Y wave, A waves. All these type of the waves we will see. So if we see in the JVP, if X descent will be there, the X descent will be prominent in. The X descents will be the prominent in both cardiac tamponade, and constructive pericarditis. Okay, I think initially I speak about the acute, but what is the main difference between cardiac tamponade and the constructive pericarditis? What we will see, the X descent, this is the prominent in both cardiac tamponade and the constructive pericarditis, and after that there is a Y descents. There will be the Y descents. The Y descent is only prominent in which condition? Constructive pericarditis. Only prominent in constructive pericarditis. And this questions came in this FMG exam about the JVP. These questions, Y descents, like related to these questions, they put some things and after that they ask you Y descents. So if you know that Y descent is only prominent in the constructive pericarditis, means that is which conditions, or we can say there is a prominent Y descents. So we can understand this is talking only about the constructive pericarditis. If X descent is prominent, so it can be the cardiac tamponade also, it can be the constructive pericarditis. But if Y descent is prominent, means that the constructive pericarditis will be answer. Okay, and we call this sign as the Frederick signs. If you want to remember these questions, then remember. If you want to forget it, it depends only on you. And the JVP will be looking like this when we see the JVP graph. So this is the C waves. After the X descent will be seen, then there is a XV. The V wave will be there, then Y wave will be there, then A wave will be there, and then again it will be started with the C. So this is the C wave, then we have the X wave, then V wave, then Y wave, or then we have the A waves. Okay. So that you need to remember. And this is the graph between the right atrium pressure. This is the graph between the right atrium pressure. The right atrium pressures versus, like we can say that the systole and the diastoles. Versus the systole and diastole. So that you need to remember. Okay. or this is what, that again the important topic, that is acute pericarditis, and we having the, then after that acute pericarditis we will be having the cardiac tamponades. Okay, that you need to remember. So as the question is saying, so we can see the heart rate is 96 and the blood pressure is 80/40. So there the dilated neck veins is there, sharply diminished apical bead. So we can see that there is a hypotension. What we can see, that this patient is having the hypotension is there, and if hypotension is there and along with that we see the dilated neck veins, so that is again the second one. And other one we have the sharply diminished apical beat, because it is what, that is muffled heart sound, that is the muffled heart sounds. So it's following which conditions? It's following the backstrides. It's following the backstrides. What will be the diagnosis? That is the pericardium tamponade will be the answer. Okay. Okay, is that clear? So this is what, that is the backstride. Hypotensions, jugular vein distensions, or you can say the neck vein distensions, dilated neck veins, muffled heart sounds or the soft heart sounds. And the jugular vein distensions, why the dilated neck veins it's occur? That is due to which conditions? Increase of venous pressures. The increase of the venous pressures. Okay, so that is the backstrides and the pericardium tamponade. Then I think pneumothorax, we already discussed about the pneumothorax. There are the some similar type of the questions will become. So let's revise those things. Okay, I'm writing it here. And this question is already done. Okay, so we discussed the pneumothorax, but let's little bit more discuss about the pneumothorax, because many questions will come about it. So there is a valvular pneumothorax, one we call the valvular pneumothorax, and the valvular pneumothorax, it is the, we can say, the type of tension pneumothorax. It is the type of the tension pneumothorax. The tension pneumothorax will be type. The type of the tension pneumothorax, and it occurs when, like in the case of the tension pneumothorax, we see that there is a tension formations. So in the valvular, what happen? There is a one-way valve is formed. It will occur when one-way valve is formed. So once the one-way valve is formed, at where? At pleural cavity. At pleural cavity. So what it the valves will do? It allow the air. It will allow the air to enter into the enter inside, but there is no escape out of that air. What will there occur when one-way valve is formed at pleural cavity? So what will be there? The air will enter. The air will enter, but no escaping of air will be done, because we know that valves. What is the function of the valves? The unidirectional flow. So no escaping of the air will be done. That's we call the valvular pneumothorax. Okay. So what we are seeing is that there is a accumulation of the air. The air will be accumulating, and this air, once it accumulates, they increase the pressure on the lungs. Increase the pressure on the lungs, and include also the mediastinum. So it will shift the mediastinum as well. Include the mediastinal displacements. So you will see that if in the question that air will enter into the lungs, and there is no escaping of the air, or you can see there is accumulation of the air, that is causing the pressure on the lungs, and due to that pressures, there will be also the mediastinal shift will be seen in these patients, and that's why we call this condition as the valvular pneumothorax. As the pneumothorax, this is the type of the tension pneumothorax. We discussed the pneumothorax. What types we discussed? The pneumothorax. The pneumothorax, it can be the open, it can be the closed, or it can be the tension pneumothorax. So there are the three type of the pneumothorax. In open pneumothorax, what we will see, the pleural cavity pressures will be equal to the pleural cavity pressure that will be equal to the atmospheric pressure. That will be equal to the atmospheric pressures. Then in case of the closed pneumothorax, what we will see, the pleural cavity pressures will be less than the atmospheric pressures. Now the atmospheric pressure will be more than the pleural cavity pressures, and we know that due to pressure gradients, what will happen, the air from the atmosphere, it will enter into the pleural cavity, and that's why we call this condition as the closed pneumothorax. In tension pneumothorax, what happen, the pleural cavity pressures will be more. The pleural cavity pressures will be more than the atmospheric pressures. The main difference, if we see that between the closed or the tensions, that is presence of what are the significant pressures within the pleural space, that is the main difference. Whatever, like in the closed we see that the pleural cavity pressure is less, but in the tension the pleural cavity pressure is more. So that is the main pneumothorax, in which you need to remember about the valvular pneumothorax. Okay, so we have the question here, the massive, the open pneumothorax and valve-like pneumothorax, and then we have the closed pneumothorax also, so that we already done. Then 35-year-old patients complained of the difficulty in the swallowing. So one swallowing we discussed, that is the eclasia cardia, other we discussed, that is the esophageal cancers. Now we see the difficult swelling and there is a pain behind the breastbone. Okay, he can eat only the liquid foods. While swallowing. Sometimes he has attack of the cough and dyspnea is there. Okay, above mentioned complaint are progressing. It is known that patient had here chemical burn of esophagus 1 month ago. What complications does this patient have? Now see, this patient had injury with the chemical burn of the esophagus. This patient had injury with the chemical burn of the esophagus. So we know one condition, that is the esophageal strictures. We know one condition, that is the esophageal strictures. There are the dysphagia we discussed about that. One thing we discussed the eclasia cardia. Other things we discussed the diffuse esophageal spasm. The other things, there is a similar things we discussed also, that is we didn't discuss that things, but the present, that is the Skatsky rings. Now this Skatsky rings is there, so this is not in your syllabus. Skatsky rings. So this Skatsky rings, it is like the circumferential and the mucosal or the submucosal thickenings. Means if this is the esophagus, so this is the circumferentials, and we see there is one ring like structure. So this is nothing, it is just mucosal or submucosal thickenings at where? At the scomocolumnar junction. So this is the esophagus, and after that there will be the gastric part will be started. So gastric part is the columnar and the above part is the squamous. So at the squamocolumnar junction we will see there is a mucus or submucous thickening, and these thickenings will be like in a ring format, so or the circumferential. So that we call the Skatsky rings. Okay, in the Skatsky rings, what you will see, the intermittent dysphagia will be seen. The intermittent dysphagia will be seen. Okay, so in that we will do the single endoscopic dilatations and these things will be done. There is a other similar things, that is we call the condition as the Lie stricture or the esophageal stricture. The esophageal stricture, or we call this as the Lie stricture, or we call this as the corrosive esophagitis. Corrosive esophagitis. So remember that whenever we will ingest the any caustic or the any alkali substance, like if we are like as the detergents, if we have due to ingestion of alkali substance, or we can say like examples detergent is also the alkali substance. So what we will see these patients will be having some clinical features like the droolings, the pain in the mouth, droolings or the pain in mouth, and also there will be in the chest. So this is, I was removing this one. There is a pain in the mouth, detergent. So that is the detergent. The clinical features what we will see in these patients, there will be the droolings or the pain in the mouth or the chest will be there, and they will see this is the ingested esophagus, and the esophagus will be looks like this, the lye, that will be looks like the lye, and you will see there is a loads of the lye will be there, loads of lye will be there. It is not the diffuse esophageal spasm. It is not the diffuse esophageal spasm. You will see there is a lye type of the structure. So only the liquid will pass in the structures. That's, and we call this condition as the lye strictures. We call this as the lye strictures, and it's occur when we ingest any alkali substance. When we ingest any alkali substance in our through our esophagus, so it will cause the esophagitis, and also it involving the drooling, and all these symptoms will be seen. Okay. How these strictures will be formed? Because after some time there will be something like when the healing will be there, the fibrosis will be healing at these regions, and we will see at the at the region where the fibrosis will occur, there is the formation of the esophageal strictures will be formed. Okay, that's what we will see, the chemical burn of esophagus 1 month ago. So what we will see, that is the esophagitis or the strictures, corrosive esophagitis and the strictures, the lye strictures. The main thing is the lye strictures. Okay, let's study more about the dysphagia, because some there was a one question about Bohr-Haave syndrome also, and the Mallory-Weiss syndromes. See, when we discussed about the dysphagia things, so there are two things, or like we have the surgical chest pains. So in that condition we see there is a one condition that I also told in the class. We see there is a Homan sign. So Homan sign we discussed, that is the Bohr-Haave syndromes, in the Bohr-Haave syndromes. So Bohr-Haave syndromes, now see, this is what we have the esophagus, this we have the esophagus, and after the esophagus we will be having the gastric parts. We will be having the gastric parts. Now if you will focus on this part, if you focus on this one, so this part will be the weakest part. This is the weakest area of the esophagus. This is the weakest area of esophagus. This is the weakest area of the esophagus. Now in the Bohr-Haave syndromes, like if there will be the spontaneous esophageal perforation, there will be the spontaneous esophageal perforations will be there. The spontaneous esophageal perforations will be there. Now see, and it involves the lower esophagus. It involves with the which esophagus? It involves the lower. Let's first write, and then after that I will explain. That involves the lower esophagus, and it's mainly seen in the elderly peoples, because in the elderly peoples this esophagus parts again become more weaker. That's why in the elderly people the Bohr-Haave syndrome is the more common. After, or in the question you will see there is a binge drinking or binge meal or heavy meals, we can say. After having heavy meals, so these patients will be released, and they see, now in the Bohr-Haave syndromes, now any person is there and that person is taking, that is the binge drinkings, like the heavy drinking. He is under the heavy drinkings, taking the 5, 6, 8, 10, 12, 15 bottles on same day. Okay, so after that what happened to that guy, or he is taking some heavy meals. Okay, he is eating the non-veg, everything is, he is just eating everything. He's looking the food is so tasty, so he's eating everything forcefully. Everything forcefully is eating. So at that times, what will be there? The intragastric pressures will be increased. The intragastric pressures will be increased. The intragastric pressures will increase. So this this intragastric pressures will increase, so it will lead to the forceful vomiting. It will lead to the forceful vomiting. It will lead to the forceful vomiting. Firstly, he was eating forcefully. Now the intragastric pressure is increased and he will do the forceful vomiting. When he will do the forceful vomiting, then during this forceful vomiting, the esophageal will rupture at the weakest point, and the weakest point is the lower esophageal point. At this weakest area, this is the, so this at this point or this area, this esophagus will rupture. The left lower esophageal, or we can say the posterolateral walls, on the posterolateral walls, weakest posterolateral walls. So what will be there? This completely, this is drinking, the food, all everything, it will be spread to the mediastinums. It will be comes to the mediastinum regions. And what it will cause? It will cause the mediastinitis. What it will cause? It will cause the mediastinitis. It will cause the mediastinitis. In that patient, what you will see? The sudden severe chest pain that is radiating to the left shoulder and the left arms. So that's why these patients will mimic the myocardial infarction. If the mediastinums, what are the clinical features we will see in this patient? The clinical features we will see in this patient, these patients will be having, there is the sudden pain and the severe pain will be there. The sudden severe pain will be there, and this sudden severe pain will be severe pain in the chest radiates to left shoulder. It will radiates to left shoulder. It will radiate to the left shoulder and to the left arms. And also in MI, what we see, there's pain in the chest pain, and the chest pain radiate to the left shoulder, the left arm. That's why these patients will be having the mimic of the what? MI, the mimic of the MI. Now also there is a air also in the gastric, in the stomach, and from this air will also enter the mediastinums, and once it will enter into the mediastinums, it will cause the subcutaneous emphysema. Subcutaneous emphysema will be there. Okay, or that's why we will see there is a triad in the Bohr-Haave syndromes, and the triad is known as the Meckel's triad. That is the Meckel's triads. That is the Meckel's triad will be seen. And the Meckel's triads, what we will see, there will be the vomiting, forceful vomiting will be there. Along with the forceful vomiting, there will be the chest pain will be seen. Other than the chest pain, what we will see, there will be the subcutaneous emphysema will be there. The subcutaneous emphysema will be there. Okay. So this we will do in case of the Bohr-Haave syndromes. This we will do in case of the Bohr-Haave syndromes. Okay, is that clear? There is a one similar type of the conditions. We call that condition is the Mallory-Weiss syndromes. The one conditions we called that is the Mallory-Weiss tear or the Mallory-Weiss syndromes. The Mallory-Weiss tear, what we call these conditions? In this condition, Mallory-Weiss tear, what you will see, there will be the longitudinal mucosal tear. There will be the longitudinal mucosal tear in gastric mucosa. Longitudinal mucosal tear in gastric mucosa, and that is what? That is the Mallory-Weiss tear. That is the Mallory-Weiss tear. Longitudinal mucosal tear in the gastric mucosa. This condition is also associated with the binge drinking. Binge drinkings. See, in case of the Bohr-Haave syndrome, there was the lower esophagus. Bohr means lower. Bohr कहाँ पे करता है? नीचे करता है ना, boring. तो boring will do lower. तो lower esophagus. Then longitudinal mucosal tear. If in gastric mucosa, M for mucosa. तो mucosa किसकी? Gastric mucosa. Which mucosa? Gastric mucosa. And this condition also associated with the binge drinking. And what we will see in these patients, these patients will be associated with the hematemesis. What is the hematemesis? What is the hematemesis? हाँ, हेमन साइंसिन्स. ठीक है, आई टोल्ड दैट आई वाज स्पीकिंग द हेमन साइंस बट गलती से होमन्स निकल गया. ठीक है, होमन साइंस इन द डीवीटी, हेमन साइंस दैट इज द ब्लड इन स्पुटम. सो ओके, उल्टी खूनी. Okay, the hematemesis, that is blood in vomiting. Okay, सूर्य वंशम वही खीर. ठीक है, सूर्य वंशम वाली खीर क्या है? That is hematemesis. So can you tell me the difference? In case of the Bohr-Havi, you will see the chest pain. In case of the Mallory syndrome, what you will see? You will see there will be the hematemesis. And the most common site in this condition, because the gastric site is the biggest, we have the cardiac, we have the fundus, we have the body, we have the antrum, we have the pyloric. Cardiac, fundus, body, antrum, pyloric. Cardiac, body, fundus, antrum, pyloric. Cardiac, body, fundus, antrum, pyloric. So which was the most common site here? That is the cardiac, and the cardiac is the most common site. Cardia of the cardia of stomach. The cardia of the stomach is the most common site. Okay, the Mallory West tear, the longitudinal mucosal tear in the gastric mucosa, they associated with the binge drinking. The clinical feature hematemesis, blood in vomiting, and the most common site is the cardia of the stomach. The most common site is the cardia of the stomach. Okay, is that clear? So this is we done, that is, and after that these questions again we already done. We discussed the difference between the central and the peripheral cancer. एक second. If you keep exhausted in between the class, then keep drinking water. ठीक है, after 10 minutes, 20 minutes, 30 minutes, keep drinking the waters. Okay, put a water bottle near you and then keep drinking little bit. एक बार नहीं कि एक बार में पूरी बोतल खत्म. वो तुम एग्जाम के बाद कर लेना. ठीक है, जो भी मतलब करना नहीं चाहिए, बट आई नो मैनी ऑफ यू डन. कौन कौन करता है वैसे? कह रहे सारे करता है सर, कभी जब मन कर जाता है तभी कर. पानी की बोतल की बात कर रहा हूँ भाई मैं. अब टॉकिंग टू पानी की बोतल. ठीक है. Okay, so let's survey radiograph of the chest of 62-year-old smokers who often suffer from the pneumonia showed a triangle shadow in the right lung. So we can see that this patient, now see, these questions we done well, by the way already. The about the uh, revise the difference between the central and the peripherals. But I'm solving this question here because in this question we have see that who often suffer from the pneumonia. So who often suffer from the pneumonia, you need to understand that this is not a simple pneumonia, this is a recurrent pneumonia because it's suffering, the patient is suffering again and again. And this recurrent pneumonia, this can be the sign of the chronic inflammations. This can be the sign of the chronic inflammation. And the sign of chronic inflammations will increase the risk of the cancer in these patients. They showed a triangle shadow in the right lung. So what you have seen, the triangle shadow in the right lung, its vertex is pointing towards the lungs roots. Now you see the vertex is pointing towards the lungs root. It shows the division of the heart and the mediastinum shadow towards the lesion. So what is the most probable diagnosis? So what we have seen, this is, if you see there is a mediastinal shadow towards the lesions. If you see the mediastinal shadow towards the lesions, it means that this patient having the something. If shadow is there, that is the, if near to the mediastinums, we can see that is the central mass in the lungs. We can see the central mass in the lungs. And the classical radiographic findings that is seen in the cancers, that is the, it is the malignant tumor. This is the classical radiographics finding in the cancer, the malignant tumor. And this malignant tumors, remember, that is arise in the central airway of the lungs, like such as the bronchi or all these conditions. And due to which, what we will see in these patients, we will see there will be the some deviations of the mediastinums, the deviations of the like you see there is a deviation of the heart also is seen, because this is present in the lungs roots. So that's why we will go for the central cancer. But most probably they will give you the either the central cancer of the lungs in the options, or they will give you in the peripheral cancer of the lungs in the options. They will not give you the both things. Lung cyst will be there, that is the fluid filled sacs. Fluid filled sac will be there, that is the round or oval. Lung abscess, like collection of the, abscess means collection of the pus within the lung tissue. Collection of the pus within the lung tissue. Peripheral cancer of the lungs, or they gave the option. The peripheral cancer of the lungs, they don't cause the deviations. What they cause? They don't cause deviations. And atelectasis, you know that the collapsing of the lungs. So these things we already done. After that, if you see that there is a sepsis is there, so bacterial infections is there, so in which that you will do the blood cultures for a pathogenic bacteria. Okay. A 44-year-old patient admitted to hospital with complaint of the dull aching pain in the left lumbar regions. So we have seen there is a aching pain in the left lumbar region, admixture of the pus in the urine. Examination revealed the grade 2 staghorn calculus on the left. So what method of treatment is indicated in these patients? So if you see there is a staghorn calculus, or you see that there will be the type 2 is there. So therefore that will be the treatment for the staghorn calculus is always the surgery. Now according to the staghorns, you need to remember we will be divide these conditions into the three types. There are the three type of the grades: the staghorn type 1, staghorn type 2, and the staghorn type 3. So the staghorn classification. In the staghorn classification, it is also, remember, it is based on the degree of involvement of the kidney and the complexity of the stones. It is based on degree of, it is based on the degree of involvement of kidney and complexity of stones, so this is based on the degree of the involvement of the kidney and the complexity of the stone. Now in the Staghorn classification, remember this is the grade 1 classification. In the grade 1, what we see, the stone involves only the upper part of the collecting system, only involve upper part of collecting system of kidney. Collecting system of kidney. The grade 2, what you will see, the grade 2, in the grade 2 we see the stone extend into middle portions. The stone extend into the middle portion of collecting systems. Middle portions. And the grade 3, the stone involves the entire collecting system. The stone involves the entire collecting system of kidney. The stone involves the entire collecting system of the kidney. So we call this as the grade 3. So Staghorn classifications, the grade 1, the Staghorn classification grade 2, and the Staghorn classification grade 3. The grade 1, it only involves the upper part of the collecting system of the kidney. The grade 2 involves the when the stone extend middle portions, and the grade 3, it involves the entire collecting system of the kidney. And remember, the treatment for this all this condition is what? That is a surgery, especially for the the grade 2 or the grade 3. Okay, in the question they already give the grade 2 Staghorn calculations. So we what will go, treatment is indicated, that is the surgery. '59, our emergency team has delivered to hospital an unconscious patient found the day today, 9th April. Unconscious patients found lying in the streets in the winter. Now we have to see the winter is there. The patient is pale with the superficial respiration, bradycardia with the heart rate 54, 2 minus 30 APs 100, palpitation, chest, abdomen, no peritoneal symptoms. There is a smell of alcohol from the patient's mouth. What is the most likely diagnosis? Now see, this type of the questions, if this patient is taking something like the hypothermia, the patient is taking the alcohol. So what the alcohol cause? Alcohol is the alcohol intoxication. The alcohol intoxications. It causes the vasodilations. It causes the vasodilations. And vasodilation, what it will cause? It increase the heat loss. It what will do? It increase the heat loss. It increase the heat loss. Okay, if they increase the heat loss will be there, these patients will be land with hypothermia. This patient will be the line with the hypothermia. As you have seen, the body temperature is given to minus 30 to 35, minus 35 degrees Celsius, and the normal temperature we know that is the 36.5 to 37.5 degrees Celsius. If less than 36.5, if less than 36.5, if less than 36.5, this is what patient is hypothermic patient. And what we will see in this hypothermia patients, we will see there is a shivering will be there, the confusion, the fatigue, and decreased consciousness. Decreased consciousness will be there. Okay, so in hypothermic, what the body will try to do? The body will try to do, the body try to conserve the energy. The body try to conserve energy. The body will try to conserve the energy by reducing the blood flow. By reducing the blood flow. The body will try to conserve the energy by reducing the blood flow to the which organs? To non-essential organs like the skin, the muscles. So they are the non-essential organs. Non-essential organs. Okay, and then they'll see there is a decrease in the heart rate and the decrease in the respiratory rate. Okay, I'm repeating it again. If the less than 36.5 degree temperature means for the patient is under the vasodilation, degree increase the heat loss, then you see that there is patient will be the hypothermic patient. You will see there is a shivering will be there, the confusion will be there, the fatigue and the decreased consciousness will be there. Now, what we will see in the hypothermia patients, the body will try to conserve the energy. The body will try to conserve the energy by reducing the blood flow to the non-essential organs like the skin, the muscles, then to the heart, then to the lungs. Because the main the main things the body wants that the brain supply should not be reduced. That's why in the end we will see there is a decrease in the heart rate and the decrease in the respiratory rate also seen. So that is the hypothermia conditions. Okay, the first bite we discussed that there is a freezing of the body will be there, and along with that what type of the symptoms we will see there is a peritoneal symptoms will also be present. The peritoneal symptoms will also be present in case of the first bite. Okay, here we have no peritoneal symptoms. Is that clear? Dun 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 dun. बोलो तो बोलो, नहीं बोलो तो मत बोलो. Okay, then after that we will be having a 48-year-old patient got a job-related injury of hypodermic varicose vein on his shin. So we have seen that hypodermic varicose vein seen that is accompanied by the intensive phleborrhagia. Can anyone tell me please what is phleborrhagia? Please tell me anybody what is phleborrhagia? Please tell me. इसके अंदर रिवर्स का बटन नहीं आता क्या? Reverse buttons like minus. Okay, I think yeah. Tell me what is the phleborrhagia? Hemorrhagic vein, hemorrhagic vein, vein bleedings, hemorrhagic vein. Okay, vein bleedings, bleeding from the vein. देखो बात का मतलब एक ही है, चाहे तुम उसको हेमोरेजिक वेन बोलो, चाहे ब्लीडिंग फ्रॉम द वेन बोलो या वेन ब्लीडिंग बोलो, बात तो एक ही है. जिंदगी चेंज नहीं हो जाती, जिंदगी तो एक ही है. तो phleborrhagia is what? That is the bleeding from the veins. So who is correct according to me? Bablu Singh Lodhi is correct according to me. ठीक है? The bleeding from the veins. Everyone is correct. That is the bleeding from the veins. So we see that the phleborrhagia is there. So in case of like we discussed before, yesterday about the varicose vein concept. So in the varicose vein, if you will see that the patients with the varicose vein. So in a varicose vein, we can use the sclerosing agents. Who wants to join now? So you will see that the bleeding like if the varicose vein patient is there, so in case of the varicose vein condition we can give the sclerotherapy, and also we can give the pressures bandage, and along with that if the pressures bandage is not like good enough, so in that cases what we will do, we do the limb strapping. What we will do, the limb strapping. What is the strapping, or we can say the limb stripping? Okay, this is the like the surgery, and the surgery what we will do, the Trendelenburg operations. Trendelenburg operations. Trendelenburg operations. In the Trendelenburg operations, what we will do, flush the ligation of the great saphenous vein with the femoral veins. Flush the ligations. Who is this? Who is Asha Sharma? So the Trendelenburg operation is there. That is the Trendelenburg operation. What you will see, the flush of the flush ligation of the GSV with the femoral vein. The GSV, that is the great saphenous vein, and what we will do, we will ligate that with the femoral vein. Along with that flush ligation, along with that we do the stripping of gestation, stripping of great saphenous vein, stripping of the great saphenous vein, because we know that in the varicose vein, this great saphenous veins, we discussed that this is what they are the main culprit. So that's why we will do the stripping. Stripping means like we will remove that and or we will ligate that great saphenous one, so the blood flow will be decreased in that conditions. Okay, that's. Is my voice clear? माइक तो साइड में पड़ा था. Was my voice clear? माइक तो बहुत दूर रखा था यार. तू बता. I don't know when it was. हाँ अभी तो बढ़िया हो गई है. Mic was far away from me. ठीक है. So the pressure bandage and the limb strappings we will do. This stripping of the great saphenous vein we will do. And if it is the case of the arterial bleedings, So if the case of the arterial bleeding, I told you, which is the best things you will do. If any trauma patients comes to you, and it come to the emergency, and you use everything, you use the crystalloids, IV solutions, you use the tranexamic acids, you use the blood transfusion also, but still the blood is still in the hypovolemic shock, and the hemorrhage is continue in that lady or in that person. So in that conditions, what is your final step you will do? What is the final step you will do? अगर एक ट्रोमा की लेडी है, एक इमरजेंसी किसी को ट्रोमा हुआ है, बहुत ज़्यादा ब्लीडिंग हो रही है, और उस ब्लीडिंग के अंदर उस पेशेंट्स के अंदर कंटिन्यू ब्लीडिंग हो रही है, तुमने उसमें ट्रेनेक्समिक एसिड भी दे दिया, तुमने उसके अंदर ब्लड ट्रांसफ्यूजन भी कर दिया. यूज फिंगर्स टू पुट प्रेशर्स ऑन द डिजिट. वाई यूज फिंगर्स? फिंगर छोटी नहीं पड़ेंगी? ठीक है, फिंगर्स छोटी रहेंगी भाई. पूरा हाथ से उसको रोकने की कोशिश करो ना. पुट द प्रेशर्स दैट डिजिटल ओक्लूजन्स वी विल डू. ठीक है, दे विल डू द कंप्रेशन, विल कंप्रेस. हाँ, I mean don't specify the finger, hand, just what we'll do, we do the digital occlusions. Okay, so what we will do, if the arterial bleeding is there, we will use the compressions band. Firstly, the last, because they ask you which is the best method to temporarily stop that bleeding. Best method to temporarily stop that bleeding. If we know that if the puncture injury and below the Poppert's ligament is the inguinal ligament. Okay, so if any injury, we know that where is the injury, the site of injury, the best method is to compress that artery, and with the help of the manually or the digitally. And if it is the case of the case of the varicose vein, in which we see there is a bleeding from the vein, so in that we will do the pressure bandage. Along with that, we need to the limb strappings. We need to prevent if the early condition is there, the early conditions we can use, like we can say to the patients that avoid the prolonged standings. We can say, because we saw that if the patient is prolonged standing, so in that conditions we see there is a varicose vein is common. So we can say to the patients, avoid the prolonged standings, and we can elevate the limbs, and after that we can use the elastic compression. Stockings can be also be used in case of the vein bleedings. After that, if still not able to treat, then we can go for the sclerotherapy, and after sclerotherapy is also not working, then we can go for the radiofrequency ablations. Then if still that is not working, then we can go for the Trendelenburg operations. If the Trendelenburg operations, what we will do with the flush ligation of the great saphenous vein with the femoral vein. And if we will ligate those vessels, along with that, what we will do, we will do the stripping of the great saphenous veins. This is your FMZ. Okay, the stripping of the great saphenous vein will be done, and we remember that if we having the great saphenous vein is there, so when we are stripping, so there will be if you are stripping the great saphenous vein, so in that things there is a risk of the damage of the saphenous nerve will be there. The risk of damage of the saphenous nerve in the great saphenous vein, and if we are stripping the small saphenous vein, so in that sural nerve will be more risk of damage. Okay, I hope you already wrote it if it's necessary for you, otherwise you can leave. It's on you. See the option, compressing a blood vessels with a clamp. There is a patient is arterial bleeding, okay? The patient is arterial bleeding is there. The already the patient's the blood already lost before also, and now you are going to search for the clamp. Would you like to search for the clamp, or you just compress that? So what you will do? Compress, directly compress. Whatever you think, you have to compress that things. Then question number 62, while making a round, a doctor had noticed the edema of the right shoulder. So we have seen that edema is there, the right shoulder, 26-old child with a diagnosis of the umbilical sepsis. This is just for the confusion, that because we have the sepsis. So sepsis, we can see that it tells us that there is a bacterial infection is there. If the bacterial infection is there, the active movement in the shoulder joints were absent. So this active movement, this like the bacterial, there will be the hematogenous spread. There will be the hematogenous spread will be there. Hematogenous spread means through the blood. The hematogenous spread means through the blood. Now you see there is an active movement in the shoulder joints were absent. Right hand was hanging down. The mother stated that the child condition. Mother stated that the child condition had worsens for the last 24 hours, what result in the child refusals to be breastfed, restlessness, weeping while sweating, rise in the body temperatures. What are the most probable preliminary diagnosis? So we call this condition as the osteomyelitis. We call this condition as the osteomyelitis. In osteomyelitis, we will be having the most probably that is the metaphysis is the most commonly affected, because metaphysis we see there is a hairpin loop like structures will be present, that due to which we will be having, and other findings also in the metaphysis, there are the more blood vessels, due to which we see there is a metaphysis the more common, but in the question they see the epiphysis, that's why we will choose the epiphyseal osteomyelitis of the humerus. Why the humerus? Because they have seen that the shoulder joints were absent, the right hand was hanging down, and that's why we will see that this is the humerus type of the conditions. Okay. Just a second. So what we have seen, osteomyelitis. Let's talk it a little bit. The osteomyelitis, and this osteomyelitis we know that is occur in the young children. It's mainly in the like the if the young children, or mainly in the elder populations, young or elders things. In osteomyelitis, what we will see, this is like we know that the myelitis, that the infections. This is the infection of the bone and the medullary cavity. And usually it affects the metaphysis. Usually metaphysis will be theirs. Usually the metaphysis will be there. Okay. Then if we talk about the route of infections, the route of infections, remember it is spread hematogenously. That is the most common route that is spread of the osteomyelitis. The most commonly it is spreading, like if you have any pre-existing infection is there, then it is spreading through that blood, and then it to the bones, and then it infects the bones. In bones it affects the medullary cavity, and most probably it affects the, usually it affects the metaphysis. Usually it affects the metaphysis. It can be direct contact. If open fracture is there, then it can also cause the osteomyelitis. If the septic arthritis conditions, that can also be cause the osteomyelitis. What is the most common cause of osteomyelitis? What is the most common cause? And which is the most common cause in sickle cell anemia? Tell me these two questions, because they are the important one. The most common cause of osteomyelitis. The most common cause of osteomyelitis. The overall or the most common. This is the croak 1 question. Siddharth, are you speaking something? Pseudomonas. The most common is not Pseudomonas. Staph aureus. Hamza is here. Okay. Hamza, write hi. Something write in the chat box. That is the Staph aureus, the Pseudomonas. See, in case of orthopedics, if you don't know anything, mark Staph aureus. If 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 in case question, if in the orthopedics you don't know anything, mark the Staph aureus. Okay, this is the like the favorite of the ortho. So the orthopedics. If it is case of the sickle cell anemia, the most common cause of the sickle cell anemia osteomyelitis, that is salmonella. That is the salmonella. You can write here the Staph aureus is equals to orthopedics. Any orthopedics questions, mark the Staph aureus. If you don't know anything, कल आके ये मत बोल देना कि आपने बोला था कि स्टेप की सिकल सेल एनीमिया में तो आपने तो बोला था ऑर्थो वाला क्वेश्चन आया था तो मैंने स्टेप ऑरेस मार्क्स कर दिया, फिर उसके बाद गलत हो गया. अब कलागी ने बोला कि सूडोमोनास, तो उसको भी बोलना पड़ेगा कि अगर आईवी ड्रग यूजर है, इफ आईवी ड्रग यूजर इज देयर, सो आईवी ड्रग यूजर है तो क्या होगा, सूडोमोनास होगा. अगर आईवी ड्रग यूजर है तो क्या होगा, सूडोमोनास होगा. सूडोमोनास इन केस ऑफ द आईवी ड्रग यूजर. ठीक है, just remember the most common cause, and if they will give you the IV drug users, they can give the IV drug users, then remember the Pseudomonas. And the most common site is that you need to remember, that is the metaphysis, and it mainly affect the vertebra in adults. The most common bones is the vertebra. The most common bone vertebra in adults. बट अगर इन केस ऑफ पीडियाट्रिक्स की बात करें, बच्चों की बात करें, इन्फेंट चिल्ड्रंस, इट विल बी द फीमर और टीबिया. द फीमर और टीबिया इन चिल्ड्रंस. ओके, व्हाई द मेटाफाइसिस, बिकॉज मेटाफाइसिस के अंदर क्या होता है, मोस्ट मस्कुलर रीजन होता है बोन्स का. ठीक है, उसकी दैट्स व्हाई वी विल बी आल्सो देयर विल द हेयर पिन लूप अरेंजमेंट ऑफ द ब्लड वेसल्स, एंड दिस विल द स्लगिश द ब्लड फ्लो, और द वीनस स्टेसिस हो जाता है ड्यू टू हेयर. In the metaphysis there will be the hairpin loop, and due to which venous stasis will be there, the hairpin loop arrangement of blood vessels. And if the venous stasis will be there, that will allows the movement of organisms, and that will result in the infections. Okay. And one thing I told you yesterday, if it is the acute, there is a sequestrums. Sequestrums, it is the origination of the chronic. Sequestrum, it is the chronic osteomyelitis. Okay, that you need to remember. If you see, there is a something like the pre-existing infection, as in this question, there is a umbilical sepsis is there. So we will be having, and after that we see that there is a problem in the joints pain and all this related to the bone related problems. So understand that is talking about the osteomyelitis. A 65-year-old patient complained of this is the direct question, the anatomical questions. Now see, there is a round constriction. We have seen there is a round constriction of the rectum with infiltrate on a height of 4 to 5 centimeter from the anus. So according to the like anatomically, if we see that from the anus, what we will see, if from the anus, the rectum have the three parts. The rectum have the three parts: the upper, middle, and lower. If it is present 9 to 13 or the 12 centimeter, then from the anus, 9 to 13 centimeter from the anus, so it is, that is upper rectum. The middle rectum, it will presents around 4 to 9 centimeter from the anus, and it will be around 0 to 4 centimeter. 0 to 4 centimeter, that will be the lower. So here we can see that the infiltrate height of the 4 to 5 centimeter. Infiltrate means like something abscess formation. So that's why it will result in the medial ampullar section of the rectum. We call it the medial ampullar section of the rectum will be the there. Okay. This is just the direct questions from anatomy. Okay, the rest questions we will do tomorrow. And anyhow, I will able to finish this week only. If I will not able to finish, like if you will not able to finish this till then, the Saturday I think you don't have any class. If on the Saturday, what we will see that we will be having long class. It can be around 6 hours, 5 hour, 8 hour, 10 hour, 12 hour, 15 hour, don't know. But we need to finish everything on the Saturday or the Sunday. Okay, so the Saturday or Sunday you will be having some big class can be there until the notice. अगर सब कुछ सही रहा, then definitely we will be have class. If not, then regular 3 hours or the 2 hours class will be there. Okay. Okay, now let's talk about the some things. Or any other questions like this you have, just write me. Whatever the questions like how many previous year papers and whatever the to do in the whatever the questions you have in your mind, write me everything and I will explain them. So I can get a little idea what it's your mind now, because you have just 1 month left. किसी के दिमाग में कुछ नहीं चल रहा, मतलब तुम पढ़ नहीं रहे हो भाई, फिर कुछ तो दिमाग में आते ही होगा ना. देखो, now we have 10 अप्रैल, ठीक है. Today we have the 10th of April and let's assume it on 10th of the May, ठीक है. And whatever the time you will get to do the one revision until that day, ठीक है. Now 10th April and you have the 1 month, so I think you should start the one paper every day, ठीक है. So what you need to do, those who are doing like I know that some of you are doing the base also by yourselves, so finish all the base, because in the therapy also we discuss the some questions regarding to the therapy, and I hear from the students, they message me that we are able to solve the questions on the therapy also. I think you are not able to solve the around 30-40 questions, but most of the questions, if you take the class properly, consistently, definitely you will be able to solve maximum questions in the therapy also. Okay, so our main target, that is I will take it, I think 10th of April, and it will be on the 15th of April. Our surgery will be there, and after that we can say that we will be have continue with the therapy, and therapy I think it will be take minimum 25th. Minimum, that is the minimum. It can be extended till the 30, I don't know, but it will be the minimum 25th will be there, but most of the topics we already done, so that's why we don't have to worry about that. And whatever the papers you need to do, the firstly you need to focus on the English questions, English paper. The English paper should be done like minimum 2015 to 2015 to 2023. Okay, I think 24 we have also. Yes, 24 we have also, because in the February we will be having February we had exam. So the 24 also, if you got the paper, do that. 2015 to 2000 paper. But I will say, once you finish this paper, make sure that every day you have to do minimum 50 questions, like from the test center website, that I'm saying from the starting. From the test center website, minimum just 50 questions every day from the test center website, every day. After that, you need to do 2015-2020 paper, 24 paper. Then you need to revise these things, like the basis again and again. Whatever the new questions, I will suggest you please send me those new questions, because you know that the obstetrics questions, the gynecology questions, pedia questions, whatever we did not discuss, because I know that there can be the new questions also, but whatever you see, there are the new questions are also there in the test center website, or in the previous years. Send me those screenshot. Take that screenshot and send me that screenshot. Okay, whatever the screenshot you will share, definitely I will make sure that you will get the explanations in the class itself. Okay, we have the limited times, because I need to give you the concept wise, and concept wise I think we will be able to finish the base only. And the question paper, the most probably I will discuss the few questions and question paper, because question paper most probably they will come from this base only. So if any new questions will be there, they send me screenshot and I will explain those questions. When the maybe I will make the PDF of all those things, and I will revise all those questions to you. Then once you revise these bases, you need to revise these bases on the regular day, like once every 5 days. Once you finish the obstetrics, then after the again 5 days, revise these bases again, or understand the concept and understand the topic. Don't do just atrophication. Once you done with every these things, like you need to we will be able to finish the therapy base and everything. Therapy base I think it will be, but once the surgery base is done, the 3 base has already been done. So after that, what you need to do, you need to start the Ukrainian paper. How you will do the Ukrainian paper? You don't need to search for the any previous year paper. Whatever the questions in the test center website, whatever the questions in test center website, do that questions. There is a one translations, like I don't know about the iPad or the iPhones, okay? Because I have the Android laptop also, so that's why I'm saying Windows laptop. So there will be the translation things. Okay, so you will be able to translate, I think, in iPad also, because in the iPad there was a note save PDF option was there yesterday. So that why what you need to do, you need to just translate that things in the Google Chromes or whatever the browser you are using, and after that, once you open that Ukrainian paper, the whole paper will be translating. There will be some few words translating problem will be there, but you will understand those things very clearly. But firstly, you need to finish those English paper and start the Ukrainian paper after that. If you are writing the exam online, 60 to 70%, if you're writing exam online, 60 to 70%, you need to be focused entirely on the test center website questions. Forget everything. If you didn't do anything, just focus on the test center website, around 60 to 70% questions. Once you're able to finish this 60 to 70%, definitely 60 to 70% you need to focus on the test center website, because in the online exams, most of the questions can be repeated from the test center website, and most of the questions will be the conceptually that you will be easily able to do. But offline exam, again, you need to be focused on the time management. For offline exams, you need to focus on the time management. And the time management, the main time management that, or the main time will be lost in filling the OMR sheet. You don't realize that things while filling, but yes, that takes some time. It takes much time. So prepare everything according to that. Like if you are sitting at 9. Sometimes if you are sitting at 9 to do the paper, don't write the paper at 9 itself. wait, keep waiting, keep waiting there, keep waiting till 11, and after that at the 11 start the paper. At the 11th you need to 12, 13 and 14. Okay, so till 3 hours you need to do the paper, and without doing anything. Whatever you will do in the exam day, do that things, because in the exam day you will be say to come at the come at 9, and they will allow you to enter at the 9 a.m. itself, and after that they can start the exam at the 11, and these 2 hours you will be completely exhausted. So prepare according to that. First times you need to prepare according to 9 a.m. according to the 9 a.m.s. Sometimes you need to start the exam at the 11 years in your during your practice test. Whenever you are doing the practice test in the previous and you're doing the previous year paper, then focus to do on the 9, and what you will do in these 2 hours, you keep revising, but don't like get up from there and do something else. Just keep studying and keep try to exhaust at that times, because once you will exhaust, then you will see that what you will do in these 3 hours. And that, because sometime they can like not in the, but most of the university they will start the exam at the 10 or 11th, but if some mishappen or something has been happened, then definitely they will start at the 11 if you are doing the offline exam. For online exam there is no issues in the timing, because whatever the times you are doing, the timings will be the same. If it is the 9 a.m. the 9 a.m. the paper will start. The timing will be no issue. The OMR will be the not issue in the online exams. There is some benefits, but you know the what are the disadvantages of the online. That will be the future. Okay. अरे अभी तो बहुत क्वेश्चन आ गए तुम्हारे. How many? Should we do PYQs from 2005? Firstly, yeah. Firstly, you need to do questions from 2015 to 2014. After that, do paper from the one thing I missed here. Thank you. That's why I'm saying keep asking me that after that, once you complete this paper 2015 2000 paper, for after that you need to do 2005 paper, 2006 paper, or 2006 7 or 8, I think they are the look similar. After that 2019 or 2010 paper, this is the must paper. And after that, if you still get the times, you can do the between, but if you will be able to do these things, definitely you will pass this exam with the great score. But if you are not, like minimum test you need to do 2020 to 14, then after 2005 6 7 8 is just like similar, then 9 and 10 you need to do. Okay, if you will do these things, definitely these are the enough, but still you are thinking that you can do more, then you need to finish the 2007 paper, 8 paper also, 2011 12 13 14, whatever things you need to do those paper. As much as struggles you will do, the more success you will get. More struggle, more practice, more hard work, more success. More struggle, more hard work, more consistent, more patience, more is equals to increase of the success rate. So that's why keep struggling yourselves, keep hard working, keep studying hard, keep consistent, keep patience, and then definitely you will be reaching definite one step by step to the success rate. But minimum things that you need to do, and focus mainly on the test center website in this last month. Okay, the next questions. When will the final revision starts, like you did for the Croak 1 in YouTube? The final revisions will be here, within the final revisions, like for the obstetrics and the pediatrics will be done, but I don't think about the surgery and therapy. ठीक है. When we will finish all the bases including therapy? अभी बताया ना भाई वो that it will be like for around 15th, we'll try to finish the surgery, and after that, after 15th to 25, we will be able to finish the therapy, or like the 10 days or 15 days we will be able to finish. Can you discuss the ये मैंने कल ही मैंने बोला that from today we will discuss. Two thousand five, 6, 7, 2005, 6, 9 or 10. These the no terminology paper in the Croc 2, right? No, there is a no terminology paper in the Croc 2. Will you teach us papers also as you are teaching 2018? हाँ. These papers, like I will discuss, because we don't have the, you can see that we don't have the time for the, firstly we will complete the focus on the base, and because that why I was teaching the 2018 paper, they look similar papers, and every questions that you need to solve, or I will discuss that through the YouTube videos. Okay, I will publish on the YouTube because of the limited times. That's why we will finish on the YouTube, and I will share you the link. Okay, 2018 paper, I think we already completed the 50 questions, and after that we will do the remaining paper, whatever the possibility. So that's why I'm saying just keep sending me the whatever the new screenshots or the new questions you are facing, so that we will able to finish that things on the times, and that will be beneficial for you also.